Okay, it's 1 o'clock. Welcome everybody to this wonderful webinar on Dln Mob. My name's Carla Trelaw. I'm from the Centre for Social Research in Health at UNSW, and I'm going to immediately hand over to our own Arnie Claire Jackson for acknowledgement of country. So Claire, you'll need to unmute yourself. You're good to go.
Okay, well, welcome everyone. I've got nearly all your pictures here so I can see if you pull faces at me and so on. I wanted to have a little blurb, just a little blurb, I've got 3 minutes, about a couple of things, and I'll introduce myself for those who haven't met me. I'm a foreigner, a Queenslander, South Queensland, which is all flooded. Some rills of mine are flooded at the moment. Again, I'm Yugarapul clan of the Yagara Nation, and I have lived nearly all my life in Sydney. I was approached by, it wasn't called the DLM then, by the department to ask me if I'd like to join the group emanating from the uni to the outposts, as they were, starting up in about 2016, Carla. And that emanated from the Mount Druitt mob, who had started up all by themselves. We got a grant and we went on. Carla's going to tell you all this in detail, but I wanted to say that why I've stayed with DLM, and while I sussed them out very carefully, and what I found was the essence of what the DLM has become, which is that it's local people running a local project from the desires and needs of their community. That's the way to go, and that's why it's successful. And I have nothing but praise for the people. I'm getting a bit teary, for the people who run the show in those local areas. UMob, that I can see some of your pictures of. Veronica and I went out and visited quite a few of you in the past, which was fabulous because you do it on your terms, in your place. And that's so rarely offered. It's top, absolutely top. So I wanted to say that at the beginning. And I wanted to say also, never, never, wherever you're living, in which nation's area, that the ancestors are there. They never leave the land. They're there, they're with you, they're watching over you. And especially you mob that are flooded at the moment and in terrible situations. And just remember that up near Lismore, the Koori Mail has done most of the rescuing, providing with food, etc., etc. We know how to survive. We know what our people need. We know what we need some of the time, not all of the time. So praise to all, and to the leaders and elders in all the districts. And never, never, never forget our ancestors and spirits in our land. So all of us want to acknowledge those ancestors and show respect towards the aunties and uncles and elders that lead us now, that share their wisdom, that do a bit of tough love every now and again, which we need. These people are our people. They keep our land as alive as we can. And we wish to show respect also to the youngsters, some of whom are amazing, coming up, learning, becoming the elders of the future. And now I'd better give you back to Carla. Thank you.
Thank you, Claire. You know, we couldn't do this work without your guidance and oversight. So we're so thankful to have you in the room today and with us as always. So I'm here today because Jen Heslop, the Heart Manager for Mid North Coast and North Coast New South Wales, is flood affected and can't join us. And in fact, we were wanting to run this webinar last August when and we decided to put it off then as Western New South Wales was battling a COVID outbreak. So we're hoping we get through today with everyone still intact and able to join us. We do have a large number of people registered. We've got 113 so far with us today, but I know others will watch this recording later on. So the purpose of today is to give an overview of how Deadly Liver Mob started, how it spread, and why various people got involved to support it, with the idea of letting other people know the ways in which they could potentially pick up Deadly Liver Mob and run it in their own places. So we're going to talk through those things, how Deadly Liver Mob started, the impact on for Aboriginal communities, the ministry's involvement, how new sites have adapted key principles to their own settings, a bit about our evaluation, and how to do it in your own site. I've also got a teenager at home sick, and I can just see him loitering in the background, so I'll just send him away. We don't want any of that. And I'm going to hand over now, but actually before we do, just to note that we're recording this. We're going to have a Q&A section, discussion section at the end, so please put any questions in the chat and I'll deal with them as we get to that point. But I'm going to hand over now to Kerry-Ann, Lou and Felicity from, Nepean and Western Sydney local health districts. Thank you. Who can talk about the origins of Deadly Liver Mob way back in 2013. Over to you guys.
Great, thanks, Carla. So my name's Felicity, and I'm going to be first to cab off the rank here. So good afternoon. I'm calling in from Darug country today, and I'm going to give you a brief potted history of the Deadly Liver Mob origins. So 10 years ago, back in 2012, the landscape was different and the supersized area health services were in vogue. So it was Nepean Blue Mountains plus Western Sydney equals the big Sydney West Area Health Service. The HIV and related programs team had 2 dedicated Aboriginal staff, one in the NSP, that was Kerry-Ann, a proud Wiradjuri woman, and an Aboriginal sexual health worker, David, a proud Darug man. This was an era before easy testing, treatment and cure went up to 60% of people accessing needle and syringe program had Hep C, and prevention was the only tool in the needle and syringe program response kit. At the time, the ministry had dedicated Hep C funds for Aboriginal Hep C coordinator positions in each of the area health services. The resignation of the Aboriginal coordinator in our district led to a decreased human capacity, but with that came an opportunity of increased financial capacity, which meant that we had room to be creative with the remaining funds. So we had money and we're working among the largest Aboriginal, urban Aboriginal population in New South Wales, that of Mount Druitt. So what could we do? The team had previous experience of incentive-driven peer models based on earlier HIV project work from 1987. That work came from the University of Connecticut, and it was the Eastern Connecticut Health Outreach Project. Now, there was a fantastic model where contact was made with drug users through a needle and syringe program. Probably all sounds a bit familiar. HIV education occurred there, and participants were incentivized to educate and bring back up to 3 eligible at-risk peers. A model where peers identified peers working through individual networks to provide HIV risk education. This work was then locally adapted in 1998 to 2003 for a Hep C project targeting young people under 25 years who inject drugs. This had been a really successful way to engage young people at a time when education was one of the few prevention tools for tackling Hep C transmission. So 10 years after, and I kind of love those timeframes of 10 years and 10 years. So 10 years after the Young Injectors Project, it seemed relevant to dust off that model, brings us back to 2013, dust the model off and adapt it for its next incarnation. So after consultation with our Aboriginal health workers, the Aboriginal Health Unit and the local Aboriginal Medical Service, the first pilot of the Deadly Liver Mob was born on Darug land. The yarning and storytelling approach to education seemed like a perfect approach to sharing health messages that were relevant, believable and useful. And most importantly, we had two team members, Kerry and David, who were keen and willing and killing to get to work, to be faces of the project working with community. And that pick was from the 2013 hepatitis C conference, where the project was recognised. Over to you, Lou.
Thanks, Fliss. So I guess for the next part, we've got to remember that now, this was 2013, so there were no direct acting antiviral treatments available at the time. Instead, the focus of the early years was just on sharing simple health messages to increase literacy about Hep C amongst the Aboriginal community. The simple messages were Hep C, what is it? How do you get it? How do you avoid it? And what do you do if you've got it? We then value added to the education by offering a low threshold Hep C screening, but because the UNSP was not a clinical service, it required some fast talking to try and negotiate a partnership with our co-located sexual health clinic. This co-location of the NSP and the sexual health clinic in Western Sydney site was perfect, but the sexual health clinic manager remained really sceptical. She was not a fan at all. She was sceptical that it could be successful, but before we started, they ran the sexual health team ran a 12-month data review of their Aboriginal attendance at the clinic. The occasions of service from that review was so poor, and more on that number shortly, I won't spoil the fun. Given that the high number of Aboriginal people living in the LGA, the numbers turning up the clinic were shocking. This result helped us to convince the manager that the DLM may actually help to boost their screening numbers. So she finally agreed to give it a go after we decided to upsize the model and include a full sexual health screen. And given that we were paying for the incentives out of the Hep C budget, she had nothing to lose and everything to gain. The central location of the service, which just happened to be next to Westfield and close to the train station and a range of community services, meant that it was an easy access point to attract participants, while the offer of incentives obviously created an extra boost to engagement at the services. At the time, the use of incentives was pretty new and it was controversial, but we believe they were important. After all, we're paid to come to work, so who doesn't like getting paid for their time? But for some people, they remain sceptical about paying people who inject drugs, especially in this era of shock jocks and unwanted media attention. There were concerns raised about safety, security and accountability, but all of these things were managed by using vouchers instead of cash and by putting some clear processes in place for the audit trail. Others raised concerns about health being seen as a commodity, and that this does still remain a dilemma for some health workers, particularly where in treatment services, where the treatment or cure is considered to be the incentive itself. But for some health issues and some populations, it takes a little extra to get them truly engaged and into the process to help them understand the long-term benefits. It's true to say that even our Aboriginal sexual health worker at the time, David, was uncomfortable about incentives. But he soon saw the benefits and realised that they're a useful way to recognise a person's time and ultimately help us to achieve our aims. Now, Kerry will give us the real crux of this, and that is the community aspect. Over to you, Kerry.
Thanks, Louise. Mount Druitt NSP made lasting and trusting relationships with the Aboriginal community, be it people who inject drugs and elders, and we quickly became a referral hub for health, legal, domestic violence, material aid, and so much more. In the first year, sexual health experienced a massive increase of 1,023% in their Aboriginal engagements. Many of our clients had never had an STI, BBV, or even a pap smear test before the project, However, trust also extended to the sexual health clinic, as many of the clients still access sexual health today outside of the project incentives, even after 9 years. The project also saw people who were visiting family in our area from all over the regional New South Wales and even into Queensland participate in the project, taking back valuable information to share. Unfortunately, in the first few years, there were many overdose deaths, mainly from fentanyl, and community grief was really high. Sexual Health made available a social worker to help deal with not only the community needs, but also for staff suffering vicarious trauma. We believe that the Deadly Liver Mob paved the way and set the scene for Hep C treatment within the NSP by demonstrating levels of engagement, trust, and client-centered care not easily previously seen when NSP was solely about needle distribution. Mount Druitt started a liver clinic in 2016, and I don't have the numbers because our team's affected by COVID, but I was told by one of the nurses, the majority of clients that have come through our liver clinic and all been cured have been from the Deadly Liver Mob project. And we've got 3 waiting in the wings for their script. Now, nearly 9 years later, we have a strong relationship with not just Aboriginal NSP clients, but many organisations that assist Aboriginal clients with their various needs. We had no idea how far what was initially just a health promotion project would pave the way in so many ways, like the research incentives, a statewide rollout, and the lasting effect on Aboriginal communities, both in the LGA and the Penrith, LGA, and now across the state of New South Wales. And yeah, it's been a fantastic 9 years. Thank you.
Thanks so much, Lou, Felicity and Kerry-Ann. The start in Mount Druitt and then extension to Nepean was so exciting, and really these data that we were seeing gave us such a great interest in expanding this. We couldn't do this without the support of New South Wales Ministry of Health, and really pleased to have Victor Tawel on the line, who was instrumental in helping us get that support. And I'm going to hand over now to Carolyn Murray from New South Wales Health to talk about why New South Wales Health was interested in Deadly Liver Mob. So over to you, Carolyn.
Thanks a lot, Carla. I just want to acknowledge that I'm on Gamma land today here in St Leonard's, and I just really want to say, actually, after that first presentation, is like, congratulations. It's such a nice thing to hear. It's been such a long time ago, as you've just said, over those many years that this started, and what an amazing project it is. And so today I'm just going to talk you through just some key parts of the program, but I also just want to acknowledge online the colleagues like Victor who worked on this project from the early days and enabled it to happen, and just recognise also Louise, Kerry-Ann and Felicity. So thanks very much. There should be another slide after this one. Thank you. So you'd be aware that New South Wales Health has set an ambitious goal to eliminate hepatitis C by 2028. And this is ahead of the WHO goal of eliminating Hep C by 2030. And since March 2016, New South Wales has treated 46% of people estimated to be living with hepatitis C, and you can see the graph on your screen there. We are below target, however, and we need to refocus our efforts. In New South Wales, our Aboriginal and Torres Strait Islander community remain disproportionately affected by hepatitis C compared to non-Indigenous people. Our recent data indicates that Hep C notification rate among Aboriginal people is 11 times higher than non-Indigenous people. Of all of the treatment initiations, only 6% have been accessed by Aboriginal and Torres Strait Islander populations in the Closing the Gaps data that we've got. So in order to achieve this elimination, it's crucial that we engage the Aboriginal communities in a range of our health services that we deliver to reduce the harms of bloodborne virus and STIs. And this is a perfect example of a project. Next slide, please. So the involvement from New South Wales Health includes 3 parts. So the incentives, looking at the incentives, the peer-driven piece and the implementation of the toolkit. So I'll just run through. Since 2015, New South Wales Health has been very committed to Deadly Liver Mob, with some grant funding committed, 300,000 throughout the life of the project. So the Deadly Liver Mob uses incentives, as you know, to support the vulnerable populations. And this model has also been used in other areas. For example, the newer project, Project Sonic, which is rolled out in New South Wales as well. And the reason that's been taken up is because we saw that it worked. We understand that incentives may not be appropriate for everyone, but in the DLM indicates the importance in this group, where the previous health promotion models had been unsuccessful until this one came along. It's a peer-led Aboriginal project. We've seen the importance of peers in the work around hepatitis C, even in some of the work we've been doing most recently. And I really want to stress that we've got a strong focus on building up and scaling this peer workforce. It's a very important part of the workforce across New South Wales for us to eliminate hepatitis C particularly. So the project's now in its rollout phase with the implementation toolkit. And congratulations to you all for the fantastic resource that it is. We are continued to be supported by Kerry Chant, and Dr. Chant's just written to all the CEs of the LHDs to encourage them to take up the toolkit and to deliver Deadly Liver Mob, and that's just happened recently. So I'm really grateful that you've asked us to have some time on your agenda today, and I look forward to hearing about more of the outcomes. I'm sorry that I can't stay, but I will watch the recording afterwards. And I just would encourage everyone to get involved with the program, and we will continue to encourage everyone to take on Deadly Liver Mob. So thank you very much.
Thanks, Carolyn. Thanks for your time today and the support of the ministry all the way through. We're going to talk you through our toolkit at the end, but go and check it out, deadlylivermob.org. It's fantastic, and it's the outcome of a NHMRC grant that we were successful in being awarded with me, Basil Donovan, who I see is online, James Ward and John DeWitt, as well as a whole heap of support from people around the place, including the heart managers and staff of the new services that we connected to. So I'm going to hand over now to Anne Ryan to talk us through the approaches from Far West and Western New South Wales local health districts. Over to you, Anne.
Mute. Thank you. Thank you, Carla. Hello, everyone. I'm calling in from Wiradjuri country, though there are many, many other countries that are within the geographical setting of Far West and Western New South Wales. Next slide, please. Thank you. We're just looking at the setting here first. For those that aren't aware of the Far West LHD and the Western New South Wales LHD, we have a little map there that's showing that we actually cover from Bathurst out to Broken Hill. We cover from the Victorian border to the Queensland border and the South Australian border. So it's a huge, huge setting. We cover from regional, rural to very, very remote. We've got very much that tyranny of distance, access to services and follow-up and what that might mean. What you can see in those little links in the is the travel time distance between places. So I can't see it terribly clearly myself, but I'm hoping the rest of you can see it a little bit more clearly. Give you an understanding of how long it actually takes. For example, it's an 8-hour drive from Dubbo to Broken Hill. Okay, we do have limited staff in our settings under the HARP services, and we don't have any health promotion staff. So if you think about this being a health promotion activity, we actually don't have any allocated health promotion HARP staff. So we rely very much on our clinical staff. So there's often those competing demands of a clinical service and then the requirements for education and health promotion. We also have limited NSP client access. We only have secondary outlets for NSP. So we We do have 2 NSP coordinator staff who are based in Orange and in Dubbo, but we have very limited NSP client access to be targeting those more high-risk people of hepatitis C. We've got those very small communities, but we actually have quite high rates of hepatitis C. Because we have those small communities, we also have that very low anonymity and a very high stigma attached with that. So that's the setting that we are out here within Far West and Western. However, if we go to the next slide, we can have a look at why we've said why we were included and why we came along and decided to participate in this project. So because of our geographic spread, because of our setting, we actually felt that we're a logical site to become part of the deadly liver mob. We do have those high rates of Hep C, and we've got significant Aboriginal communities. And by that, within Western New South Wales, 11% of the population identifies as Indigenous, and the Far West, it's a little bit higher at 13%. So if we're looking at an activity, an peer-driven incentive activity, then we actually were quite a logical site for the inclusion of this program. So what did we do with the services? Look, it's been really, really good. The incentivised program, which as has been explained, was a new approach. It did have some controversy around it when I asked to participate and contribute to that. And as I think Kerry Ann mentioned before, there was some opposition to that, or it might have been Louise. So within the LHD, you do, if you're looking at running this type of program, there's a lot of negotiation and liaison that you need to do to talk about the program. But it is a key strategy for engaging and retaining clients, and it's definitely informed a lot of the Hep C elimination work that we're continuing on with. So it's established that very much community-focused incentivised strategies. It is effective, it is appropriate, we're using the local peers, and it's really essential for engaging clients and linking them back to care. So some of the partnership examples, so we've got to think a little bit, and the next slide will talk a little bit more about how it's actually differed from different organisations. So we've had different partnerships that have come about within each of the LHDs. Some of those partnerships have consolidated internal partnerships, and some of them have been more external, where we've been working with other service providers that link into, treating and working with high-risk people of Hep C. So in Far West, our situation was that we actually didn't have an Aboriginal worker. So this was a bit of a bother, considering this is a peer-led approach and we needed to have an Aboriginal worker. So we actually needed to create and recruit to a position. So that took us a fair bit of time, and so our initial rollout was a bit behind some of the other local health districts, but that was okay because we were learning as we went. And one of the, I guess, the really good things about this program is that you can actually tailor it very much to your local situation. Because we had no face-to-face NSP, we were able to establish outreach to become safe client spaces. So how we can actually bring clients in through that incentivised program and actually work very, very closely with our new Aboriginal worker, and how we're able to link that back to community. So it was very important to have those safe client spaces for people to feel comfortable and culturally safe coming in. So with the outreach needs, what we actually did was we developed within Far West a portable education resource. So this resource was very much focused and created with the local Aboriginal worker and some of the local peer group who contributed to make a resource that was very simple was very, very easy to understand, relied predominantly on pictures, and that resource has proved very, very significant in and ongoing in the Far West area. The response that we had for the challenges, again, was around balancing the staff time. As I've said, in Far West at this point, we had the 2 other clinical staff and we had a 0.6 Aboriginal health workers. So it was obviously balancing the staff time and their capacity and the demands they were doing versus the level of community engagement. So I can't emphasize how much time it takes to develop that trust with community and that understanding of what this program is actually about. In Western New South Wales, it was quite different. We had 2 Aboriginal sexual health practitioners who were able to participate in the Deadly Liver Mob, and you'll be hearing from Clayton and Bev shortly. And they were very much able to look at refocusing ways of working with the NSP and the clients who would be utilising the NSP. In Dubbo, we have an established NSP. So yes, it's a secondary service, but we've got a worker established there. And so people were coming into the centre. And by that, we're able to develop new outreach models to be used regularly when the new clients were declining. So I'm sure Clayton and Bev will talk about this a little bit more, but as we looked at the NSP recruitment and the no face-to-face at other sites, we were looking at different outreach models where we were already providing services to and where we could potentially provide the Deadly Liver Mob in conjunction with our other activity. So it was balancing that existing work and managing the community engagement around the Deadly Liver Mob. So they were sort of our challenges that we put in and the modifications that we tried to bring to the program so it would work within our local health districts. Thank you. If I can have the next slide. Okay, so our key learnings. Incentives are effective. They're definitely effective. They definitely bring people through the door. However, they weren't to the level that we had hoped for. We really thought this was going to be the wonderful game changer and we would actually access many more people through this service than we actually did. Now, that's not negating. They are definitely effective. We definitely got people through for the education, we got people through back for screening, we got people through back for the follow-up, for their results, we got them, people into treatment, but it just wasn't as much as we actually had hoped for. Look, the learning was with the incentives, it is very much an encouragement for people to get screened and to know their status. So we're trying to say it's really important for people to know their Hep C status. And look, we've come to the conclusion that any incentive works. Even a cup of coffee will get people in. So, these incentives did work well. And we're actually looking at continuing them on, like in the adaptive point that I've put in there, that we didn't get into the Sonic program that Carolyn talked about, but we're already running a similar type program called Positively Hep, which has actually opened up this incentive type program beyond just the Aboriginal population. It's for the non-Aboriginal population. And we've also been running Blitz Days. So it's beyond that initial target group that you can actually implement this program and make it work for your settings and see how it goes. I think one of the major key learnings for us is that all that importance, that development of that relationship of trust. And again, I think it was Kerry Ann who made that comment of how important it is to get that trust, and then people will continue to come back to the service. And we've definitely found that occurring in our sexual health clinics, that people are continuing to come back, they trust the service, they feel safe coming back to that service. So that's been fantastic. The linking into care has also been that opportunity to offer other testings. So when we're talking about getting people in under that testing for Hep C screening, we've been able to offer like vaccinations, we've been able to offer, you know, that STI testing. It's just that development of trust, that initial focus for Hep C. And even if people weren't positive for Hep C, that trust then has developed into those broader areas. The last thing that I'd like to raise as a key learning, again, I'm talking about the two local health districts, that the focus is heavily reliant on that consistent, confident and skilled Aboriginal workforce with those strong community connections. Having Bev and Clayton based in Dubbo, having their local knowledge, already running clinics out in the Western community worked really, really well in Western. In Far West, it was a little bit different. We ended up having two Aboriginal health workers come through in the timeframe of the project. It worked initially. It didn't work so well. It worked again. It didn't work so well. I think that whole concept of having a consistent peer, a consistent Aboriginal worker is really, really important. It can't be emphasised enough to really run this out and to develop that trust in the community. Now, it's acknowledging that every small town each have unique challenges. So no matter where we were going, there's always challenges. And some of those things are the setting that I originally talked about in access to care. It's that anonymity, it's, you know, that stigma that's associated with some of the services. Sorry, am I going over time? I'll quickly finish up. One of the key learnings that I wanted to emphasise, and again, it's because of the way our staffing is and the staffing capacity, is that all staff should be giving the same message and the same information, whether it's Aboriginal or non-Aboriginal, male or female, ensuring that cultural safety and cultural choices. In the timeframes when in Far West, when we didn't have an Aboriginal health worker to be the front person of the deadly liver mob, we still ran the deadly liver mob service with the other staff that were there. And as long as we are developing up that same message, same information, then, and we had that link from the initial launch of the project, we were able to continue on with this and be able to give that same message around the Hep C education that's required and screening and then linking into treatment. So no matter where the community is or who's actually working with them, they should always be getting the same information. So on that note, I think I'll finish up. Thank you.
Thanks, Anne. And we're going to stop the presentations in a PowerPoint way for a moment and flick to the frontline expertise that you mentioned, Anne. So I'm going to hand over now to Mitch Beedman from our centre, who's going to run us through a conversation with Bev and Clayton, as Anne was referring to. And I just wanted to check whether Larissa was on the line, knowing that Larissa's in flood-affected areas might not have made it today. But while we're checking with Larissa, Mitch, over to you.
Thank you, Carla, and thank you, Anne, for your presentation. So I would like to start with my acknowledgement of the land that I'm on. I'm the Aboriginal and Gadigal peoples of the Eora Nations land. So just to start off with, Bev and Clayton, I'm not sure who wants to go first, but if you wanted to just give a bit of a background on your role within the DLN program.
Yeah, I think I was initially the the main person for the DLM. Yeah.
Yeah, and plus having the clinical roles, it sort of helped us along the way with it. And yeah, so we've done a lot of groundwork to get it underway.
Okay, and how has the community responded to the DLM program?
Yeah, first, so we ran our program to start with out of the NSP service, which is the very first room as you enter our clinic. It was very slow to start with because clients were always in a hurry to they just wanted to come in and get their fit packs and leave, and a lot of people had people waiting for them in the car so they could just pull up and jump out and grab them. So they were always in a hurry and they didn't really want to stick around to talk about it, but they always said they would come back in again and do it. And we initially only ran it for the one day, picked a day through the week to hold it. And yeah, like I said, it was still pretty quiet. So, and then when people came in on other days, we didn't really want to knock them back to say no, we come back on the day that it was originally meant to run. But so we sort of opened it up to whenever, any day of the week. So if anyone wanted to come in and talk about Hep C and that, we would definitely let them do that. So
yeah, and
it also increased too when we took the program to other towns and services. And
okay.
Some of the services with promotion.
Yes.
And promotion.
And that was taken up well within the communities.
Yeah, in some communities, yes.
Yeah, very well. Some.
Yeah.
Yeah. And what type of barriers did that break down?
Barriers.
So. Well, pretty much when we started doing the outreach, we took it to the methadone clinic here in Dubbo, and because we were in the building as they come in the door, it worked really well because they would get it done before they dosed, or whereas in some other communities we were in a different building, so it was harder to get people to come across once they dose because some people just wanted to get their dose and then go home, or in our clinic, it started off a bit difficult because we had our NSP worker who's not Aboriginal, and he was always there to start, but so we sort of switched over, like when we would at a certain point of day we would set in the NSP and work it from there.
Yeah, that's really good. And what I'm hearing is that the DLM program has been a bit of a stepping stone to sort of create more relationships of a conversation with Indigenous people within the community about a conversation around hepatitis. Is that what you guys have found?
Yeah, like due to the past treatments and the side effects, the new treatments that people have taken up, some people are still a bit wary of it because of past side effects. And then some of them that had the treatment saw their colleagues and decided, the treatment wasn't too bad after all. Yeah, and they're becoming aware about the treatment, how good the treatment is.
From a clinician's perspective, how important is it for the clients, for the patients and clients to have an Aboriginal face to sort of talk with about a sensitive issue such as hepatitis?
Yeah, well, it's pretty important that they speak to an Aboriginal person. And there's a lot of people around our community that we know and we've seen before, so they're quite comfortable in engaging that with us. So yeah.
And plus the stigma that is that goes, you know, not only from the health staff, but it's from the community as well. You know, they felt at ease with us talking to them.
Yeah, so that could be one of those barriers. So stigma is definitely a barrier that was probably not broken down, but definitely addressed. Yeah. And the benefits and the value of the DLN program that you both saw within your communities. Speaking broadly, what about the vouchers? How were the vouchers received within the community?
I think they were, as like Anne stated, it worked, and it encourages access to the health. So yeah, and it really worked, and it was a good thing. I think the vouchers or fuel cards, mobile credit cards.
And most outreach sites, once they found out that we were giving out vouchers, we got swamped with people coming in off the street, wanting to be tested and talking about Hep C. So yeah, it worked very well.
Okay. And the education process, just to sort of, we sort of skimmed over that a little bit earlier, but I just wanted to sort of go through that. What type of things would you talk about with the patients and clients in the education process?
Basically, just explained what hepatitis C was all about, the risks of transmission, and how it can be transmitted, and also talked about treatments, new treatments, and well, what else?
And there's and we talked about the difference between the antibody test and PCR test, because a few were tested by their doctors, and only the antibody test was performed.
Okay.
So we followed up with that, and a few of them came back negative with PCR test. Quite a few.
Right.
Yeah, so they were really surprised, and that was a really rewarding part of the program for us. You know, that they were pleased with it, that they cleared the virus.
Right. Well, thank you so much for sharing your knowledge and expertise, and your contribution to the DLN program. And I'm going to hand back to Carla. Yeah, thank you.
Thanks, Mitch. And a great convo with Clayton Anderson and Bev Tyson. Just fantastic knowledge and expertise that all of the people involved bring to the project, but none more so than, how do you actually work with community to bring people through the door and keep them engaged? So we've heard about Mount Druitt and Penrith. We've heard about Western New South Wales and far Western New South Wales. Change of pace completely to come to inner city Sydney. And I'm going to hand over to Gary Garn from KRC to talk about your experience with Deadly Liver Mob and what successes, learnings you bring to the table.
Excellent. Thank you, Carla. And thanks to everybody for this opportunity to kind of come and share some of our experiences today. Before I start, I would like to acknowledge the Aboriginal health workers who have taken the lead around implementing this project here at Kirkton Road. They being Kathy Kostovsky, Michelle Ellis, and most recently Elsie Amamu. This project would never have been able to achieve what it's done without their leadership. Next slide, please. So I'd like to just kind of just touch briefly around what we as an organisation have learned through our participation with the programme. And some key areas are, so Kathy coined the phrase of clinical yarning, and participating in DLM enabled our Aboriginal health officers, our health education officers and our clinicians to interact regularly with Aboriginal community members, Aboriginal elders and opinion leaders. In relation to connecting with community, one of the main reasons around this was the DLM provided a platform and an opportunity for Aboriginal community members and our staff and other services to have conversations around viral hepatitis, around health, and to actively listen to each other. Next slide, please. The role of the Aboriginal health workers in developing trust and rapport with clients has been touched on, but I think what DLM also offered was a really effective mechanism to enable non-Aboriginal staff to build trust and rapport based on regular participation with DLM activities. And the idea of empowerment, front and center of all of this project. KRC is a big clinical service, it's got 60 staff. There's a range of things going on, but what DLM enabled our Aboriginal health workers was to provide a really highly visible leadership role, and for them to take the key part in engaging with community members. Next slide, please. In relation to developing partnerships, we ran DLM across a number of settings, one of them being the Wayside Chapel. And through the work of DLM and through the trust and rapport we built, not only with their service users, but also with their program workers and managers, it meant that the partnerships that we had developed flowed on into other areas. So, for example, when COVID hit the inner city, we were very quickly able to pivot and develop a range of outreach programs with the Wayside Chapel, accessing both homeless Aboriginal communities and non-Aboriginal communities. But the mechanism around that partnership was formed through our interaction with the deadly liver mob. And then finally, just talking about cultural healing practices. What we were able to demonstrate, again, DLM provided us with a very effective mechanism for integrating health interventions within Aboriginal social and cultural spaces, which again had a kind of a magnifying effect and an amplifying effect for some of the health programs that we were running. I want to tell you a story. Sarah's not her real name, was a 32-year-old Aboriginal woman with 2 children that was previously unknown to KRC. We first met Sarah when she started attending the weekly mob lunch at the Wayside Chapel, one of the settings that KRC had negotiated to host the DLM. For over 12 months, the same KRC staff attended that weekly lunch with Aboriginal community members, these being Kathy, our Aboriginal health officer, Gary, the project manager, and Anna, a highly skilled clinical nurse consultant. Over approximately 4 lunchtime meals over spanning a month or so, Kathy had developed a rapport with Sarah, and Kathy introduced the other KR staff to have kind of social interactions. Over time, Kathy also gently raised the topic about whether Sarah would be interested in taking part in DLM. Sarah agreed to do so, completing the health education session with Kathy and the introductory BB bloodborne virus assessment with our clinical nurse consultant in a private room at Wayside. And based on that assessment, it became apparent that Sarah had had very limited access to health services previously and had a number of health issues that required further investigation. Kathy's role was crucial in facilitating and supporting Sarah to attend our main KRC clinic for a more comprehensive assessment, including a full sexual health screen and a cervical screen. Sarah had reported that despite being 32 with a number of children, she had never had a cervical screen previously. The results of that cervical screen subsequently identified some abnormalities that required referral to a specialist service outside of KRC. And again, Kathy worked with Sarah to attend those specialist appointments. And for us, this story highlighted how culturally safe programs such as DLM enabled both Indigenous and non-Indigenous staff to overcome the inherent inequities that can act as barriers for Aboriginal communities in accessing health services and preventative health. And next slide, please. And my message to services who are considering, who are interested in DLM, DLM works. But in terms of any kind of trepidation that you may have in relation to accessing the program, start where you are, use what you have in terms of your resources and connections and referral mechanisms, and do what you can. What you know, we've heard from other services here today and from our own experiences of DLM, it grew into a really comprehensive bells and whistles program. It doesn't have to be that. Do what you can. There's a range of people across the state with a lot of expertise who are willing and kind of really energized around this program. It absolutely works. We've really enjoyed what it's done for our ability to engage with Aboriginal community members. So if you're thinking about it, get on board. Thank you.
Wow, Gary, I think we need to pick up your salespersonship there. That was awesome. Thank you. And when we get to the toolkit, we'll show how we've explained how different places have modified the kind of core principles of Dead Live Mob to work in their own places. And some people have spoken about that already. Part of the connection, or the way in which Dead Live Mob operates, is the connection to clinical services. And Donna Tilley is our next speaker, who is a nurse practitioner in the sexual health service in Western Sydney. And Donna's going to talk about how that connection across the NSP and into sexual health worked. So over to you, Donna.
Thank you, Carla. Hopefully you can all hear me. I've got a slide with a photo of us, so hopefully you can go to that one and see our team. So my name's Donna and I'm a nurse practitioner at Western Sydney Sexual Health Centre here at Mount Druitt on the Direct Land. And I've been in this role since 2017. So I didn't start with the Deadly Liver Mob program initially. This is a photo of myself with Kerry Ann Smith, who you've heard from already, our Aboriginal Health Education Officer, and the nursing and admin staff. So this is kind of our team on any given day. So we're co-located with the needle and syringe program at the community centre in Mount Druitt, and it's a true co-location in that there's really just an open door separating our services, so people really don't have to go to another place to see us. So the DLM program has created ongoing links and positive relationships between the staff, in that we're striving towards that common goal of increasing education and testing for Hep C, bloodborne viruses and STIs in the Aboriginal community. And we know we'll often have a catch up on our clinic day, find out kind of what's going on, and just always keeping that relationship going, which is so important for health promotion. The DLM program incentives really support engagement with the service, and particularly with people coming back for additional visits. So that first visit of where people get their education and have their first test, but we really want people to come back and find out their results, get their vaccination, and the incentives are a huge draw card for that, because that's really the point where people can drop off. So that's been fantastic. And once the changes to the Hep C treatment were on the PBS with the direct acting antivirals, people were able to come back into the program here at Mount Druitt and receive incentives to update their knowledge about the new treatments, which was fantastic. So would deliver an update, and because it had been a significant amount of time since they may have been for their last checkup, people can kind of just book in with the sexual health clinic and just have another screen, which has been great. Over the last 2.5 years, we've also had staff changes and also changes to nurse practitioner prescribing, and we can offer treatment for Hep C at our service, whereas previously we referred to the liver unit for treatment. And it's anticipated that people might choose to stay with the sexual health service if they prefer, rather than go to the liver unit for their treatment. But it's definitely a personal preference and an option, but it gives people another choice of somewhere they might go. And another benefit that we've talked about a lot is that ongoing trust the community has with our service. And we continue to see people from the Aboriginal community for sexual health issues, because they know this is a culturally safe space to come. They see Kerry's face on their entry into the service and say hello on their way through. And we've also got some great connections with the Aboriginal Health Unit, also based at Mount Druitt, and have started doing outreach for women's health screening days there. And there's a lot of future connections that could come through that. For us, COVID has created many challenges for the Deadly Liver Mob program, particularly the entry requirements into the health building with no outreach, no walk-ins. And that was one of the main ways that Aboriginal people will come into the service, and we have space all the time for walk-in, and that hasn't been possible during COVID because of the health department restrictions. So we're planning now about how we can reinvigorate the DLN program and look at new venues. There's an outreach bus that the liver unit has, whether we can use that, and also building new partnerships. So we've had a vacant Aboriginal sexual health promotion officer position for a while, and that's being recruited to soon. So hopefully with some new ideas, new connections, more Aboriginal staff, we can actually do some more work with the Deadly Liver Mob, which we know works in the Mount Druitt community. Thank you.
Thanks, Donna. And I'm sure services across the state, across the country, across the world are working out how to reinvigorate as something happens out of COVID anyway. So we've heard mention across a number of people the outreach work that's done. And so we've invited Anna Scott from St Vincent de Paul, based in Coffs Harbour, with services up the coast. So again, really appreciate your time on a difficult day to talk about what's in it for partners to become involved with Deadly Liver Mob. So over to you, Anna.
Hi, thanks for having me. Just for the first slide, please. So I oversee a number of drop-in services along the North Coast, but specifically today we're going to talk about Pete's Place, which is a homelessness drop-in centre located in Coffs Harbour. So it's a drop-in space for those experiencing or at risk of homelessness, but we see people who rate highly on social exclusion scales across the board. We have about 60 people per day dropping into our service in a space of 5 hours, so it's incredibly busy. We create a place that is very focused on relationship building, focused on safety, focused on building trust. Once we have that engagement, we have that kind of non-institutional place where people feel comfortable, we bring in the wraparound supports to kind of create a more holistic framework for wellbeing. Over 50% of the people that enter our doors identify as Aboriginal or Torres Strait Islander. Next slide, please. So NSP first became involved with Pete's Place at our request. Through talking to the people that visit us, a lot of them identified as being intravenous drug users, and we were starting to notice a lot of unsafe practices that were happening. We really want to take a harm minimisation approach. In addition to that, there has been a bit of a what's affectionately known as tent city established behind the service. So a lot of makeshift campsites have established there, and we've been getting quite a few complaints from people about sharps being found in that area. So we approached NSP and asked them to come in and work with us, and they were really willing to do so. They started visiting daily, giving out some fresh equipment, providing education. They then talked to us about the idea of bringing Deadly Liver Mob program into the space. They thought it was a great place probably to have that program come because of the high rate of Aboriginal people accessing our service, and because it was a place where people already felt comfortable. We agreed to that, and the Deadly Liver Mob program came in and was really very successful. We had a really high uptake of people wanting to attend, lots of people, agreeing to or wanting to get tested. And from there, it's led to a lot of further engagement with, particularly with the HARP team. We now have dry blood spot testing here weekly, and we're about to scale that to our other drop-in services along the coast as well. We've had vaccination clinics that have been able to come in and, I guess, utilise that collaboration that we already have and that framework that we'd already have that have come from our engagement with the Deadly Liver Mob program. Next slide, please. So what worked and what we learned, the vouchers for us was not just an incentive, a monetary incentive, but it was also a way to reduce stigma. People were able to come in and say, yeah, I'm keen to get tested, but it's just for the voucher. It's not because I'm concerned. I'm just here for the voucher. We had a lot of people taking that up. So the vouchers worked for us in a number of ways. We learned that word of mouth is powerful. So once the program started here, the word spread pretty quickly, and a lot more people came in, wanting to engage in that space. Obviously, engaging people here in a way and in a space that feels comfortable to them is best practice. We do that in a number of ways with other health services. The Aboriginal Medical Service comes in, Centrelink, lawyers, etc. This was a great extension of the services that we provide. We also realised that the testing needed to be extended beyond our visitors who identified, which is why we now have the NSP team coming in weekly, and they're doing high numbers of testing, dry blood spot testing each week. The education for our staff as well, from the Deadly Liver Mob program and then from the NSP and HUP teams going forward, has allowed a really beautiful continuity of support and collaboration. So we've learned a lot about Hep C. We didn't know a lot about it going forward. It means that we're all able to reiterate the same messages, to talk to them about different treatments. We've been able to increase adherence to medication by looking at what barriers we were seeing. People were losing their medication, for example. So we set up a program and a system where we could store that and be giving it out in weekly doses, because we're seeing people each day, or daily doses, depending on what worked for the people. We identified some large clusters of Hep C positive people in our space, and we've been able to clear most of that. However, the testing does continue weekly, which has been fabulous. I think that's it. Thank you.
Great, Anna. What an amazing story from Pete's Place there, and would love to hear about the extension you're going to do to other services as well. That would be awesome. We're going to turn now to our a bit of time to present some of our evaluation data. So I'm going to hand over to Eleanor Karma from our team at the Centre for Social Research in Health. Over to you, Eleanor.
Thanks, Carla. So I'd just like to start by acknowledging that I'm talking to you today from the lands of the Wongal people. So my name's Eleanor. I'm part of the research team at the Centre for Social Research in Health, and as part of the NHMRC partnership project, we've been tasked with evaluating DLM. Can you just go to the next slide, please, Karen? Thank you. So the aims of the evaluation are threefold. Firstly, to evaluate the effectiveness of DLM as an intervention, to look at client and staff attitudes and barriers towards acceptability and uptake of DLM, and also to develop an implementation toolkit. So hopefully that would help for the introduction of DLM at any potential new sites. So the evaluation aims to mirror the program in its research design. It's low threshold. We collect very minimal new data about clients. And the reason for this is that we don't want the evaluation to introduce any new barriers for healthcare access for First Nations people. It's a mixed methods project. We largely draw from a range of sources, but largely from routinely collected data from the sites. So that includes the health promotion data, which is the incentives provided to clients and their eligibility for the program, through interviews with clients and staff, through linkage with sexual health data already collected by sexual health clinics, and also through an issues register where we aimed to collect any implementation issues in as real time as possible throughout the life of the project. And I'd just also like to add that we are exploring ways that we can also access data on Hep C treatment, but that's proven to be quite challenging due to the changing nature of the way that Hep C treatment has been provided since direct-acting antivirals have been introduced. So today I'll be speaking to some of the routinely collected data through the health promotion side of things. Kim's going to talk through some of the interviews with clients, and then Karen will talk through the implementation toolkit. And this is such a small snapshot of what is an incredibly rich data set that we do have, but we really wanted today to be about getting the perspectives of the sites around how they ran things, what worked, and what their learnings were as well. But we are in the process of publishing these findings from the evaluation. So if you just keep an eye out through either the Deadly Liver Mob website or through the hashtag on Twitter, there should be news, hopefully, of publications later this year. Next slide, please. So this first graph that you see represents the cumulative engagement of clients in DLM over time. So this is from the beginning of the evaluation. So that first time point there is 2013, when there was no engagement, no DLM program, through to June 2020, which was the event at the end of the evaluation period. It's really important to acknowledge that the COVID pandemic really impacted on the sites and their ability to implement DLM in 2020 onwards. And as others have mentioned, sites are only just currently start restarting the program and looking at ways that they can reinvigorate and re-engage with clients. So the yellow line on that screen represents the number of people who have been educated over time. The red is the number who went on to screening, and the purple is those who went on to receive the results. And I'd just like to draw your attention to, the different time points. So looking at, May 2016, where 2 pilot sites were running. Then in 2017, at the next point, we had all sites except 1, keeping in mind that there's a total of 9 sites within 7 local health districts. So overall, you can see that that DLM has engaged 1,787 Aboriginal clients in education, which is just amazing and a real credit to the teams for all their efforts. Of those, 1,316 went on to be screened, and then 753 returned to receive their results. Next slide, please. So this slide really shows that same data, but in a different way. So we call this the Cascade of Care, and the idea is to look at the points at which people engage in the program and where they might sort of drop off the cascade. And what we hope to do is then use some of the other data sources like, the issues register, interviews with clients and staff to look at what are the barriers and facilitators to the program, why do people actually drop out of the program, and then those learnings can then be used for any future sites who are thinking of implementing DLM. So this graph shows that, all clients who enter DLM receive that initial education session on Hep C. Of those, 74% go on to be screened, and then 42% of everyone educated receive their results. And there's a note there just to mention that's 57% of those screened receive their results. We are going to publish quite a bit about this data later this year, but I do want to highlight that all of the sites, no site is the same. Each of the sort of setups is very different. So there are different barriers depending on the site. So there could be issues like, which I think Kim will touch on, issues with parking. People just want to be able to get equipment and go home. There might be challenges for people to travel to sites in rural and regional areas. And so that data is really important to contextualize this data that I'm showing you on the screen. And we do hope to publish that later this year. Next slide, please. And just finally, just to talk about the incentives. So this shows over the life of the project for those 3 main outcomes of education, screening and returning for results, the investment in the incentive vouchers, which are supermarket vouchers for clients, is $56,220. And that's really not a lot of money for, this program has been running for several years, and to be able to engage, over 1,700 people in an education session, 1,300 in screening and 750 for receiving those results is really a minimal amount. That's not the only incentives that are provided. So I do want to mention that clients may also receive incentives for other sexual health, like receiving Hep B vaccination, or if they require STI treatment, and also for referral of peers. But we just wanted to highlight that those 3 key outcomes there for the Cascade of Care, just how minimal that amount is. I'll now pass over to Kim to talk through the interview data as well. Thank you.
Hi everyone, I'm Kim and I'm a proud Wadi Wadi Wanneroo woman from La Perouse, and today I'm talking to you on Bidjigal land, and I acknowledge elders past and present and all Aboriginal people present today. I also want to acknowledge Melinda Walker, who started these client and staff interviews before me. So overall, the things that the DLM clients said worked well were the vouchers, the education, the testing, the treatment, and having an Aboriginal worker up front, and the positive impact that the testing and the treatment had upon their health. And we've put together a few quotes here from DLM clients. And the first one said, "I reckon it's a great incentive, one of the best. It encourages community to get themselves sorted out and at the same time get a little bit of tucker with the vouchers. So then you walk away saying, well, I might have had a blood test, but I'll be eating well tonight." The next client said, "I thought it was great because of the education and the vouchers. I was scared and it was good to find out the results and know what I needed to do. I reckon the mob at DLM are cool. They understand that some people are scared. Some of us are really nervous about the whole thing, but I think you mob have got it down pretty much pat. Karen, can we go to the next slide, please? I thought it was good. They were also educating community on how you can catch it, how you can treat it, and where you can go to get it treated. It also helped us to learn how to protect ourselves. It felt good to know that you've got people to back you up. That really helps. I was surprised because at the GP or at the hospital, if they ask you if you use or if you have Hep C, after you've been diagnosed with it, they kind of frown upon you and it makes you feel terrible shame. DLM helps community get you better, and it gives you information on how to do that. You knew that they were trying to hurry you. They weren't trying to hurry you through just because it was their job. They really cared and they wanted us to know the information and spread the word out to our mobs. I still go back there and say hello, and if I needed anything, they always helped me. It's a good service. My health has improved. I've started to put weight back on. I felt the service was good because I felt comfortable, and I would recommend it to our community. The vouchers are also good. And then our final client said, I ignored my Hep C after having it for 20 years because I didn't care about it. But when I was in the prison, my mob said, well, you might as well get that sorted out now and cure the Hep C. So I was the first one to do the new Hep C treatment, not the interferon, the other one. I was a guinea pig to start that one. And so it cleared my Hep C. So after 20 years, it was cleared in 2 months instead of the other 3 or the other drugs that took 3 to 4 months. Kieran, can we go to the next slide, please? And here's what some of our DLM clients said could be improved in the program. It was a real consensus that parking needed to be improved. Having dedicated DLM spaces would work, and more information out on the streets advertising DLM. There's just not enough information out there in our communities. The point is, if mob don't go in and get fresh kits all the time, or if you're just using old ones, you miss getting information about DLM and Hep C. So you don't really hear about it unless you go in there for a clean kit. And that's all. So I'll go back to Carla, I think.
Thanks, Eleanor. Thanks, Kim. Great data there. And I'm going to throw to Karen now to overview the toolkit. And Karen, I'm going to give you the challenge of 4 minutes because we've got a great couple of questions in the chat. Over to you.
No problem. I'll be really quick. So I just want to draw everyone's attention to the online implementation toolkit. This is essentially a collection of instruments that will allow you knowledge about DLM and how to set it up in your own site. And it gives you all the resources and materials that you need to do this. So this toolkit was written by Carla Trelaw and Eleanor Karma. It was designed and built by the Design Embassy in collaboration with Auntie Claire Jackson and graphic designer Emma Hicks. So I'll just do a quick tour. Let's do it less than 4 minutes. Basically, it's set up to allow you to move through the DLM program or to go directly to bits that are of concern for you right away. So you've got information about the program itself. Really importantly, there's also information about why incentives work, because that's often something that comes up with healthcare services. It takes you step by step on how to run it, even gives you troubleshooting options, and also how to evaluate it as well. So you've got the evaluation that Eleanor talked you through, but also it gives you the tools to do your own evaluation. So just a quick note on some of the design features. These are also the resources that you have available at hand, so it gives you everything that you need. In fact, I think there's even photographs of how to set up the education trays under these resources. So just a really quick note around the design. Emma Hicks is an amazing First Nations graphic designer who designed all these little flora components, and they guide you through. So it's actually really a visually stimulating website, if we do say so ourselves. And the other thing is we do actually engage with the multiple modes of information. So we've got beautiful pictures. We've got videos that have been taken by DLM staff. We've got quotes from clients and easy to follow diagrams. So I'm going to end there and just encourage you to go and check out the site. You can go there straight through the QR code. But also, if you are on the site, we really appreciate getting your feedback. there's going to be a really annoying pop-up survey. Please don't shut it down. Please take a moment just to let us know what works for you in the toolkit and what doesn't work. And you can come back to us over time, especially as you're going through the process of implementing it and letting us know what information was useful and what wasn't so useful. Okay, so that's me done.
Thanks. That's an example of a researcher begging for your attention. Very nice, Karen. There's a couple of great questions in there, and I'm going to start with the one from YouthLink. Sorry, I haven't got your name there, about engaging with elders who might be resistant or not supportive of programs about people who inject drugs. So Carrie-Anne Smith, over to you for you to talk about the ways in which you're thinking about responses to that question.
Okay, well, obviously when the pilot project started, it wasn't the research project. And we saw quite a few elders come into the project and they talked and shared lots of stories. They were on board with it. Our elders here are very active in the drug health scene. They've held ICE rallies and things like that. So they were really on board with it. We decided that to educate the whole of community was to help to reduce the stigma. So the elders did a really big part out here, especially one elder who has 4 generations in their house and was unaware of the the low risk ones of toothbrushes and razors and stuff. So we didn't have any backlash at all. We had nothing but support from them. In hindsight, we probably should have talked to them first, but we didn't know it was going to go this far to begin with. So, yeah.
Great. And I'm just checking with Clayton or Bev, if you want to jump in and talk about the experience in Western New South Wales working with elders out there.
We found the elders weren't that interested in the, because they had other, looking after their grandkids or whatever. They seem to be interested in the program.
I did have a couple of elders that were interested in it, especially in small towns like Glargan and that, because I did have an older guy who was still currently injecting that, and he was very keen to get some information and stuff about it and treatment.
Great, thanks. So I do remember from talking with the first couple of sites that you did take a couple of elders through the program in, I can't remember if it was Mount Druitt or Penrith, to explain what happened and so on. Does anybody want to talk through that process?
Oops, sorry, Carla, it's Lou. I was thinking that exactly what Carrie-Anne was saying, that initially I think there was kind of a little bit of a curiosity factor that some of the elders were coming in saying, like, what on earth's going on? And Kerry and David were able to engage them just in the conversation, say, hey, you want to find out about it, this is what it is. And by actually walking them through and giving them a whole range of options, that it wasn't all about injecting drug use, but, had any of their family or their mob been in prison, the risk factors that were not specifically talking to injecting drug use, meant that they were pretty curious and keen and became some of our best sort of salespeople. There was one family, I remember, Carrie-Anne, that went home and sort of said, that's it, I'm going to send everyone into you, and became the kind of the champion to pass the messaging on. So I think it was probably just taking away the little bit of fear that we were somehow promoting drug use. Maybe, Kerry, is that?
Yeah, well, they were certainly very interested, but that calmed down rather quickly after David, mostly me doing the education and taking them through it. And
giving people some familiarity with it, right? And it's not scary, and it's not promoting drug use. It's a proper health service and doing the right thing.
Yeah, more or less promoting health, a healthy lifestyle, because back in the day when we started, there was no DAAs. So, and how we, you know, we gave them good education on how to live with it. You know, what sort of foods that are good for you and stay away from all the sugary stuff. So, and the deep fried stuff. So, yeah, there was, good messages got through.
Awesome. So on another topic, Jack Wallace has put in the chat questions about where's Hep B figure in all of this. So I wonder if anyone wants from the Deadly Liver Mob family wants to pick up about how Hep B figured in the program.
I'll have a go. Our sexual health clinic tests for, you know, hepatitis B antigens. As we know, there's a lot of Aboriginal people who don't hold immunity even after vaccinations. So in the first, I don't know, maybe 3 years, we found a lot of people had not had those vaccinations. So we paid, they got when they came in for the results, they got told that they have to have Hep B vaccinations. So that was that $10, and we also paid them to come back for the second and third. So it really is inclusive in the Deadly Liver Mob project. Yeah.
I might also point out that in the online toolkit, the resources that are available allow you to track instances of hepatitis B as well as C.
And I might just add, Carla, it's Donna here from Mount Druitt. So we have hepatitis B vaccination here in the clinic for free as well. So people don't need to go to a chemist or go anywhere else. They just come in and they can have that vaccination at the visit.
Really important info there. You know, got to keep addressing the social determinants of health, including cost as a barrier. So very important stuff.
We offered, we offered the Hep B screen and vaccines. Yeah, vaccination. Yeah, that was all into the screen. It went through everything. Once they done the Hep C, they wanted everything done.
Yep, awesome. So we've also got in the chat a great comment from Pete at Hep WA about their Torres Strait Islander worker, I think it is, with deep connections to local Indigenous people there, that creates a great pathway into the services for liver, hep and sexual screens and care there. So that's great. You know, that's the same kind of pathway we've been talking about with Deadly Liver Mob. We've got 3 minutes left. Time for one great juicy question to pop into the chat. And while that might be percolating, I just wanted to say, you know, this has been an incredible experience for me to be involved with over all these years, and the products that we've produced, the research papers, the implementation toolkit, draw on the expertise and knowledge of all these people you've heard from today and more, people that have been involved and have now left, and people that have helped us along the way. So I wanted to say a bloody big thank you to everyone for your awesome contributions and making this program a massive success across New South Wales, and for today to be able to say, here, everybody, go and have a look and use the principles, resources, tools of Deadly Liver Mob for your own settings and services, and let us know if you pick it up and use it. We'd love to hear what people think of this. So we might finish. We've got 2 minutes left. We'll give you everyone a 2 minute.
Can I just say something, Carla? So,
go, Victor.
I just want to say, having been there in the ministry at the beginning, and remember when you and I and Carrie Ann and Elizabeth, may she rest in peace, were sort of trying to talk about how can we make this something that could be rolled out across the state. I just wanted to say thank you to you, to Carla, to Carrie Ann. I'm so glad you're still around, and to everybody up in the Western Sydney and you know, up in that area in particular who started this. I think for me at the time, it was important that we do something to consolidate. Well, I know great work was happening, but no one was actually listening to it. The great work for Aboriginal sexual health workers, the importance of increasing the number of Aboriginal people that come to services, and to document all those things and the incentives, and to have something concrete at the end, like the toolkit. So from my perspective, having been there at the beginning, this was the vision, and I think you've captured it really, really well. So congratulations and thank you.
Yay to all of us. And there's a lot of love being shared in the chat. So thank you for that as well. And Victor, what a champion right from the beginning. So thanks everyone. Go and check out the website. We just love your feedback on it, and use it. That's what it's there for. So thanks to all the presenters. Just awesome work from all these wonderful colleagues. Stay safe, stay dry, everybody.